Well, good afternoon, everyone. I hope everyone had a good lunch and mastered the noodle boxes. I'm Jennifer Blake. I'll be your moderator this afternoon. And I really want to thank you for coming today for the session where, as I said in my opening remarks, I hope this puts down the day where we begin to set ourselves on the course to eradicate cervical cancer in Canada. We heard on Tuesday that when you introduce yourself, you should say where you're from and why what you're talking about matters to you. So let me just say that throughout my practice, I've had a colposcopy practice, which then I then started a cancer survivors clinic up at Sunnybrook in Toronto, and that Cancer Survivors was particularly devoted to women who'd had gynecologic cancers. So started seeing the impact of cervical cancer on women and women's lives. I had a patient in the office just 3 weeks ago who was a 36-year-old mother of two at her postpartum visit. After her 2-year-old was born, she was found to have an invasive cancer. She has been treated for that. Her baby is now 2 years old, and she has had a recurrence of her cancer and is now going into salvage therapy in the hopes that she can be saved. She's got about a 40% likelihood of survival. This is a preventable disease. In putting our title together, we said, can we eradicate this disease by 2030? That number wasn't sucked out of thin air. It was because the Global Fund had suggested that we could eliminate tuberculosis, malaria, and HIV by 2030. And I thought, this is a far more preventable disease than any of those. So why is HPV not on that list? And I'm really happy today that at the World Health Organization, Tedros Ghebreyesus has said that this is a target that we should, as a world, take on, not just for countries like Canada, but for all the world. We can eliminate this disease. But it takes more than having a good vaccine. It takes more than having a good screening program. It takes more than having early treatment. It also means that we have to have a population that really engages with this and understands that vaccination is safe and that screening makes sense and that treatment can, in fact, prevent cancer and prevent the tragedies that we see from this disease. And so I'm particularly pleased that we have a wonderful pair of speakers to address this topic today. Professor Sylvia de Sanjose has studied the role of HPV in cervical carcinogenesis for more than 20 years. As part of the Cancer Epidemiology Research Program at the Catalan Institute of Oncology in Spain, she's been involved in a wide range of activities devoted to understand the natural history of HPV infection and its burdens worldwide. Over the last 10+ years, she has coordinated a large and international study on HPV genotyping in cancers of the cervix, vagina, vulva, penile, and anal cancer. And Sylvia, you're currently president of IPPV, yeah? So I could not be asking for a more authoritative voice on this. And Dr. Blake Murdoch, Mr. Blake Murdoch is, I'm not going to make him a gynecologist. He doesn't, that would be a surprise, come away from the meeting and you're turned into something you never expected. He's a research associate at the Health Law Institute, where he's worked for the past few years with Tim Caulfield, who we all know. Blake's recent research interests lie at the intersection of misleading information, unproven interventions, and public policy. Blake currently sits on the Canadian National Transplant Research Program's Data Safety Monitoring Board and teaches a portion of the biotechnology policy at the University of Alberta's Faculty of Law. And I think you can appreciate why we think it's so important to have Blake's perspective on how we can help improve our uptake of these strategies to enable us to eradicate cervical cancer. So with that, I'd like to invite, is it you, Sylvia, that will be doing the first presentation? Okay.
very much for your presentation. I am now working at PATH. PATH is an NGO based mainly in Seattle, US. And there I moved to PATH because they do a lot of implementation work for many diseases and specifically for cervical cancer. And since last October, I am learning a lot and trying to implement preventive interventions in Central America and probably in the near future in some countries in Africa. And really, I am learning a lot about the difficulties to implement what is very clearly available in Canada or in Australia or in Northern Europe, and how hard it is to reach other populations. And this is my effort now that I am doing. And as part of being the president at this moment of the International Papillomavirus Society, I have been able to encounter many voices not trying to move towards what can we do, how altogether we can move from research to real practice and trying to make this available to all the people at risk. So I passed this. So I have no conflict of interest and everything has been reviewed adequately as stated by the organizers, and I thank them for inviting me to be here. And what I would like to just to go quickly together, it's about the concept of elimination and eradication and trying to see what's happening in the world, but what is happening in the two parts of the world, in the very rich atmospheres where women can access to both to vaccines and to screening, and what is happening in the rest of the world where maybe one single visit will be the best expectation that can happen. No? So as a member of the International Papillomavirus Society, we published a short report a couple of years ago just stating that we can move towards elimination as a concept, mainly to put on the table, on the political arena, this is a priority. And we know that we have to think carefully what elimination means, and we will talk about that, no? And this was together with, as mentioned before, with the message of WHO that it was stated in May that reiterated that we can move and we can bring this to the United Nations General Assembly as a real target, no, elimination. And so we are together. I am now part of the technical team that tries to develop how we talk about elimination. Still is unclear, but altogether goes as well with the Montreal Declaration that aims to, by the year 2030, to have the 90-90-90. So 90% of the women should have access to health care, should have access to vaccinations, should have access to an adequate treatment. And this is all very important. It's already in many arenas, and this is helping to bring funds. I think it's helping to move the machinery towards these idealistic approaches, and we try to make them real. So in terms of theory, and we understand as eradication, that we have talked with Jennifer before, and she wants to eradicate the disease. And for eradication, it means that the worldwide incidence of the disease has to go to zero as a result of deliberate efforts, obviating the necessity for further control measures. And this example is the smallpox. While when, in theory, we speak about elimination, is the reduction to zero of the incidence of the specific disease in a specific geographical area as a result as well of efforts. But there is a need to continue intervention measures because the disease has not been eradicated globally. And that's the case of neonatal tetanus. This was published in 1998, and generally we follow this definition as the dogma. But when we went to WHO and start talking, okay, how we can really think about elimination of cervical cancer, first of all, it's very clear that if we have a timeline, elimination has a country-based arena. So we cannot talk about elimination in the world. We can talk about elimination in Canada and maybe in Australia, one of the most advanced countries in terms of prevention of cervical cancer. But still, we encountered that there were some few countries that the incidence of cervical cancer was very low. Can we say these countries have eliminated without doing anything, are in the pocket of cervical cancer is eliminated? And there was still, we have discussions about that. We have to think, can we consider that these countries can stop doing any intervention for the potential cases they may have because they have eliminated the disease, so there is no need to engage some of these countries in vaccination of their population. It's something, I don't have the solution, it's on the discussion table. And what is clear is that none of the tools we have today to prevent invasive cervical cancer can really lead us to zero incidence. First, there will be cases in between screening intervals that will appear, and we don't know how to handle this because there are fast-growing tumors or failures in our screening tools. And as well, the vaccines may cover. We now have a nanovalent vaccine that can cover up to 90% of the cervical cancers, but we still have 10%. So eradication today with the available tools is not really something in the prospect of this century, I would say, unfortunately. So if we are realistic, we can then go and work and say, okay, let's go if we can eliminate. So as I mentioned you before, there are some countries, I think this is a laser, I don't know if it's a laser. No. You can see Palestine is one of the countries with the lowest incidence rate, 2 per 100,000. So should Palestine not to think of vaccinating their girls? Egypt, Iran, Jordan, they do nothing about cervical cancer. They don't do screening, they don't do vaccination. Only very few women in the very private sector would have access to this. So when we were talking in WHO about where do we put the level of elimination, we said, okay, we have several countries that they can already show they are flag. They do nothing, and so it's because of the risk factors that they are accompany the HPV infection that makes them to have such a low rate. But we still have several countries with the greenish color that they are in the lower bound, and these countries like US, like Canada, like Australia, like many countries in Europe are devoting a lot of effort. So these efforts are the responsible for the rates to be so low, okay? So to be in the lower bound. And we have seen that by doing this, by doing a lot of screening, we have seen that countries, and here's a selection of countries, have really going down very much, no? Their incidence rates throughout the last 20, 30 years. And we see, however, that there is a plateau. Like, there doesn't seem that through screening we cannot go below 5 per 100,000. That's like a plateau we have in the rich countries. And so we have to think, if we put the elimination level at 6 per 100,000, then it means that all these countries have eliminated, including almost Canada, it's 6 per 100,000. So could have been eliminated the disease. And you don't like that. You don't want that, because we don't want any case that can be preventable too. So the scenario is, do we have to put different levels of elimination in rich countries compared to poor countries, and leaving the Arab countries that they have really very low incidence? Like making 3 levels of elimination scope? I am not sure WHO would like that, but in the Nordic countries, you can see here the shape of the incidence by age group of cervical cancer. This is combining all the Nordic countries, and the highest shape represents the earlier curve of incidence in the 60s, and it has taken over 40 years to go down to doing a lot of screening, a lot of investment, no? And this has just bring here an example that in Finland, it takes about 34 million euros to generate these very low rates every year. So it's really very costly, and the country can afford it. But this is a privilege of few. So in Canada, you know that you have about 1,400 cases a year. You really want to go down, although it's still the 13th leading cause of cancer. Is very low. It's among the lowest in the world. No, it's in the lower bound. But you are a rich community. You have resources, and you want to do it better. So. You have not done much, let's say, in terms of time trends. So it has been quite stable. The overall in the last, this stops 2007, and I could not get the graph for more recent data, but you are now at an incidence that I think it's 8 per 100,000. It depends if you do an age standardized. I think it's 8 per 100,000. So still there is a room. Finland is at about 4. Doing the similar efforts that you do, you could really halve what you have now. So that's a possibility. No, we can do more, and we have to add here the impact of the vaccines, which will come, but it will take many years. In Australia, which is a country that not only has done a big effort, but has been very proactive in publishing their data. They are getting data very rapidly. And they were the first to publish the almost the elimination of genital warts by using the quadrivalent vaccine in extended cohorts in women from, I think it was from 9 until 20 something, that they provided the vaccine massively. And you can see in the thicker line how it dropped so much that they are almost closing the clinics for genital warts because they don't have any more clients. No? It's good. And what they have done, and they are still now, it's coming very soon, an updated version of that, is they were trying to model whether they could really project the elimination boundary. Like they put it here in this paper, 3 per 100,000. And what you can see, that this effect is by introducing HPV DNA testing as a screening tool with an interval every 5 years. For those that they are negative, and if they are positive, they have a triage test that can be, there are several approaches of triage, but really efficient way to handle preneoplastic lesions. And what they see, in addition, they add the vaccination program, which is massively accepted in the country. And so what they see is that as soon as this is implemented in the population, there is a peak, there is an increase in reporting of lesions. Why? Because we are improving our detection approach. We move from Papa Nicolau to DNA tests. We are better. So suddenly we see an increase in the burden of disease, but then it follows by a descent. And the descent reaches, at the end of 2035, they say, an incidence of 3 per 100,000. So this is the most recent publish data for Australia, and now they will publish the scenarios of different approaches worldwide. So, but I cannot report them now because they are not yet in the press. But you can see yourself here. I think really Canada could fit in this model very well. The global scenario is terrible. We have, like in red here, many countries that women are reporting no screening ever at all. So this is the reality of sub-Saharan Africa. And the reality in Latin American countries is that they get a Papa Nicolau, but the Papa Nicolau gets in the storage in a corner, and very rarely the woman receives the result of this Papa Nicolau. So very ineffective policies. When we try to see what happens with the introduction of HPV DNA tests, you can see in dark blue the countries that they are already incorporating this in their programs. In sub-Saharan Africa, the most common screening approach whenever it's available is visual inspection. As you know, visual inspection is a very poor test, a screening test. So still globally, we are doing very poorly. In terms of vaccination, we have estimated that 82 countries in 2018, have introduced in their national programs the vaccination. So there's still a lot of areas in Africa have only demonstration projects. That means that they have introduced the vaccine in a very small scale, and as well in many of the Asian countries. So still a lot to do. And here for me, it's the most important slide I have to show today, is that here we see in the different parts of the world the number of expected cervical cancer cases that women that they are today alive are going to generate in the forthcoming 65 years. So the blue is the number of cases in the different age cohorts of today that they are going to develop cervical cancer. This is about, I think, totally is about 38 million cases we are all going to generate, all the women that are today alive. In yellow is the number of cases that we think we have averted by vaccinating and by the screening that we are doing today. So as you can see, the yellow part is larger in high-income countries and a bit in upper middle-income countries, is almost null in lower and low-income countries. So when we see these numbers, and I think this has been really a scenario that has been reached by Gates Foundation, by WHO, by the different research groups, and say, wow, we were so happy having the vaccines, and now when we model what's going to happen, we see that still we need much more work to be implemented in order to really make a major impact. And although in high-income countries we have, as you can see, the volume of cases is much lower, still we were thinking we were doing a lot of work, and still is we have a lot of work to do. So I think we have to generate cohorts of men and women that they are free of infection by vaccinating our target cohorts. We need to provide a screening with validated and efficient tools to target women. We have to provide accessible, efficient, affordable treatment to screen positive women. I would tell you that in my experience in some of the Central American countries, screen positive women, sometimes 60% reach to treatment access, 40% no treatment, even if they are detected as screen positive. So we have to make sure that we have tools that they are acceptable and affordable for these populations to make a change. In Canada, by 2030, I think we need to have, Mark Steven had estimated that we have to vaccinate 1 billion of young females and screen 2 billion mothers and grandmothers to reach these 90% estimates. So in conclusion, I think we are all aware that cervical cancer is a preventable disease, we have an obligation to contribute to free of virus generations through vaccination. This is an obligation we all have as professionals. And best secondary screening and treatment must be implemented and be adapted to resource availability, and we cannot just hide the limitations that are available around the world. And I think Canada may be able to claim elimination in a relatively short interval. Thank you very much for your attention.
I may be persuaded by the end of the day to settle for elimination, but probably to 0. Blake, can I invite you to come up? And
Thank you.
thank you, Sophie. That's great.
Okay, so I'm going to try standing over here. So I'm left-handed, so my brain works funny. So anyways, today I've been asked as a non-doctor, as mentioned, to speak a little bit about the other side of this, which is the public opinion side. As we know, medicine and technology are not going to solve the problem alone, given the challenges we're facing in the public sphere. So here are my disclosures. I have to say, by the way, thank you for inviting me. And this has got to be the best conference I've ever seen in terms of mood lighting. It's really great. I feel like Steve Jobs up here, but you know, I probably should have worn my blue jeans and black turtleneck. So here are all my disclosures. So learning objectives were mentioned in the program, but generally what I want to cover today is first talk a little bit about vaccination attitudes in Canada, look at media representations and the sort of false balance that exists in the media, talk a little bit about the claims being made by some alternative practitioners, so naturopaths, et cetera, touch on issues surrounding social media, viral fake news, et cetera, and then discuss, you know, what can we actively do to try to mitigate these issues. So I don't need to cover this part. We know that HPV vaccine is really the path to getting rid of cervical cancer, or eradicating it, that is. So I think it's clear too that with the HPV vaccine, it is subject to similar false beliefs as some other vaccines. So actually, Angus Reid in 2015 did a study on vaccination attitudes in Canada. I'm not sure if you saw this when it came out, but basically, they asked a few important questions. One was, as a general rule, do you think vaccinations are effective at reducing the chances of catching disease for the individual getting vaccinated? And so across Canada, you know, representative sample, we saw just over 50% said very effective. Then another big chunk said mostly effective. We saw, you know, 11, 12% say not very effective or not at all effective. And you might notice that Quebec is actually over 20% in terms of not very effective or not at all effective. So that's an area of concern. I'm not sure what's causing that, but and then another thing they did was ask, you know, yes or no, do you agree with this statement? And one of the statements was the science on vaccinations isn't quite clear. And I'd like to focus on this because 39% of those surveyed said yes, the science of vaccinations isn't quite clear. 28% said that they do believe there's a real risk of serious side effects from these vaccinations. So let's think about that 39% for a second, how significant that is. I mean, that's enough voters to elect the federal government. So, you know, it gives you some concept of the scope of the issue. I'm Albertan, I'm not talking about this federal government, I'm just saying in general, it's a serious issue for sure. So what's causing it? I think some of you in the room probably have some ideas, and we of course know that Andrew Wakefield has had a very horrible effect and harmed a lot of people with his ideas around autism and MMR vaccine. This is an interesting study that came out just this year here, showing that actually misbeliefs about MMR and autism reduces people's intentions to get a new Zika vaccination. So you can see that those issues are spreading beyond to other types of vaccines. And in the media, we're seeing issues around false balance. So false balance is the idea that, you know, for vaccination and against vaccination will be put on in the newsroom and presented on equal footing and given equal time to speak as if they're somehow equal. And so this has been studied by academics. And so, for example, this study in 2012 looked at readers and assigned some of them to a balanced condition where they were getting that kind of false balance. And the people who were exposed to that were less certain that vaccines did not cause autism and more likely to believe experts were divided on the issue. And here's another one. Again, participants in the balanced condition perceived less agreement among the experts in general and were less likely to think there was enough agreement among experts on the high consensus issues to guide government policy. And so when we think about false balance, the most obvious classical example is Jenny McCarthy on Larry King Live being placed opposite two CDC scientists. And the question is, who do you remember of that exchange? I have no idea who the scientists are, but I very much remember Jenny McCarthy, and that speaks also to the power, of course, of celebrity in influencing public opinion. They definitely are very sticky in the minds of the public. So this is was a big story in 2015, came out in the Toronto Star, talking about Gardasil. And you probably all saw this when it came out, given your vocation. So, you know, they said that they analyzed Health Canada's regulatory database for reports, found 50 serious incidents, including 15 hospitalizations related to the vaccine. And they also said they found over 100 deaths in the US. So this was caused a big backlash from probably SOGC or GC, I'm guessing. But so they did come back and then, you know, said that they failed and let down the readers. However, in some ways, the damage is already done. You know, there's the idea of mere exposure that exists in psychology. As soon as you've been exposed to the news, even if it's fake and you know it's fake, it still affects your opinions very subtly. So, you know, they ultimately were relying on anecdotes from people who believed that they were hurt by the vaccine, and they completely ignored all the independent studies from millions of women showing that it's safe. Here's another study from 2016 that looked at 2012 to 2014 American and Canadian media content about vaccines. And when they were looking at the negative reports, they found the negative sentiment was highest in reports around about vaccine safety. And indeed, 15% of the negative sentiment was related to HPV vaccine, and the most common issue was, again, vaccine safety. So then there was Michelle Bachmann, a former US congresswoman, who stated that the HPV vaccine causes mental retardation, is what she said. This was a serious event as well in the US. This study looked at 200 articles in the media that analyzed, you know, the media response or coverage of that event. And about 50% corrected that statement, and 40% provided a counterpoint. So we're very far below, you know, where we should be in terms of what the actual science says. And you can see here that, you know, newspaper engaged in the highest level of truth-telling, whereas online and blogs, which are both online, I guess, engaged in the least amount of truth-telling. And again, balance was given in a lot of scenarios where it shouldn't have been. So that's the media side of things. Then there's claims by alternative medicine practitioners. So naturopaths and other practitioners often push anti-vaccination perspectives. Not all of them, I'm not trying to generalize. But here's an example from, this is from Arizona. This is a website, Gardasil Reasons for Caution. You know, they're talking about the National Vaccine Information Center Gardasil Risk Report that showed 10,000 reports of issues with the vaccine. 2,000 were classified as never recovered, 25 deaths, 54 cases of paralysis. And you know, if you look into the NVIC, it sounds like it's a government organization, but it's actually the most powerful anti-vaccine organization in America, and its relationship with the US government largely consists of trying to stop efforts to get children vaccinated. So but you can see how a regular person would be confused by that. Regular person, lay person, non-doctor is what I mean, of course. So this is a study that we did at the Health Law Institute, and we published this in the Journal of Law and Biosciences last year. We looked at 330 clinic websites for Alberta and BC naturopaths, and we found 53 had either vaccine hesitant language, suggested a vaccine alternative, that being like a homeopathic no-sode, or had both. And of course, no-sodes are very dangerous because if they're used as a replacement, you can imagine the harm that could come. So moving on again, talk a little bit about social media. So I'm not sure if you're aware, but the 2016 election in the United States, viral fake news election stories outperformed real news on Facebook. This is just to give some context of the power of fake news. So if you look at August to the election day, you had 8.7 million shares, reactions, and comments on Facebook for fake news, and 7.3 for the biggest news organizations in the United States, mainstream news. And it's posited that fake news spreads quicker because it's usually more shocking or controversial. So HPV has actually been analyzed, I guess, by academics in the context of social media. Now, I'd like to see a good Facebook study because we all know that's a very dominant form of social media. MySpace is not exactly dominant anymore, although it was when I was in university. I had a pretty sweet page. But, you know, this study studied 303 blogs about HPV vaccination. They found that 43% were classified as negative about it, and 52% positive. You know, YouTube is also has been analyzed for immunization. This is not really specifically to HPV, but in this study, they found 48% of videos about immunization generally were positive, 32% were negative. Here's one specifically about HPV on YouTube. Now, this is a little bit older, right, October 2008. But they looked at 146 unique YouTube clips and found that 3/4 are positive, so I guess that's good, but doesn't reflect the actual efficacy of the vaccine, of course. So that's just a brief outline of some of the issues and some of the areas that are causing problems for vaccination. So what can we do to actually change public opinion and behavior? Well, mandatory vaccination has been raised. Obviously, this has been put into effect in some countries, especially for the more, you know, the vaccines for younger children. So Australia is doing it. California had their vaccination rates for kindergartners reach an all-time high when they passed a bill getting rid of personal exemptions. And actually, Florida, in January of this year, had introduced a Senate bill looking at making HPV vaccination mandatory in Florida. And this was super exciting. It was going to be July 1st in a few days, and it didn't even end up getting through. It ended up having opposition mount against it, and then it was dropped. And in this article is interesting, Rhode Island was the only US state with requiring HPV vaccine for both male and female students, starting with the first dose in 7th grade, and they had the highest rate of vaccination, unsurprisingly. So this is certainly an option for Canada. There's some potential issues, first with just public acceptance. There is, of course, a perception. I would say there's likely a perception that HPV vaccine is not as crucial because it's a lot of the serious harms occur in the distant future for small children. That could be an issue. There's also the sexual method of transmission, and that could create a perception that herd immunity isn't as important, especially perhaps among religious folk. You know, there's a factor of, oh, we could just be abstinent. Well, we know that we can't really be abstinent as teenagers. We've all been through it. So beyond that, some other difficulties, legal difficulties. Of course, there is the charter right to bodily integrity under Section 7 of the Canadian Charter. There's the potential for legal challenges by anti-vaxxers who lose access to public services for failing to vaccinate. Of course, we're never going to have a law in Canada saying that we're going to forcibly stick a needle in you, but you know, not allowing you to go to public schools if your child's not vaccinated, that's an option. But there are rights to education as well, so those could be legal challenges in the court. That being said, I think that in general, it would be best to continue to routinize HPV vaccination and pass, you know, mandatory vaccination laws and kind of deal with those issues as they arise, because they can be dealt with by the judiciary. So I also wanted to put a note in here that we can't really control mass media. It's as a group of doctors or scientists now, we can contribute to the messages that exist on them. On those platforms, but the platforms are really in the control of very few select corporations. And actually, the corporations are more powerful, I would say, than government regulators as well. So, there's the ability to hold the corporations more accountable, but that's probably the first place to start. In terms of alternative medicine misrepresentations, like I mentioned earlier, we've proposed several steps at the Health Law Institute. So first is, truth in advertising law. If you're making any sort of efficacy claim about a homeopathic remedy or no-sode, that's false advertising under Canadian law. It's just not enforced very often, so there would need to be enforcement efforts. There's the issue of self-regulation. So naturopaths, have the ability to have their own colleges in many provinces in Canada and discipline themselves. Now, we've held historically that when you don't have evidence-based practices, you can't maintain an evidence-based standard of care. So we disagree with that at the Health Law Institute. And then the other stuff I'll skip because I don't have a ton of time. But so what can we do? This is a book that the director of the HLI, Tim Caulfield, had published recently, just educational with some interesting artistic representations. But, in terms of messages for clinicians and communicating with people who are hesitant, this is a very important study from 2005. It showed that they talked to people about vaccination and provided evidence of vaccination. They found that 25% of the students interviewed were less likely to recommend the vaccine after being provided with the evidence supporting it. So there's this issue that confronting deeply held beliefs can paradoxically strengthen them. And here's another study really showing the same thing. There's limited effectiveness to regular types of vaccine interventions using facts. Facts don't really work in the post-truth era. And then here's an example of what can work a little bit more. So this study found that they had success countering anti-vaccination attitudes by making people appreciate the consequences of failing to vaccinate their children rather than focusing on undermining the widespread myths about vaccination. So I guess basically they could have said in here, we scared them. Then in addition to that, there's some new research coming out that there's the narrative type of storytelling is very powerful in terms of changing people's opinions. So combining narrative and statistical information can be very effective. And there's kind of like a review published in March of this year that I thought was very interesting about communicating with these sorts of discussions about vaccination. So these were kind of the findings of a review of various studies about communicating about vaccination. First of all, the strength of the provider's recommendation strongly influences parents' perceptions. Second, brief recommendations might be best for parents without significant concerns. So if they're on the right path, don't confuse them with more information. Presumptive recommendations, which are basically announcements rather than recommendations in a sense, are associated with increased HPV vaccine update. And that one's a little bit touchy because you don't want to fall into the trap of being the doctor who doesn't sound like they're giving you a choice or whatever. And then for people who are hesitant, especially parents, motivational interviewing techniques, which is something that can be trained, that you can be trained in, and it's focused on addressing the primary drives of parents, so making sure that their children are safe, et cetera. So combine all that, you kind of have the best practice here. Brief, strong, unambiguous language to introduce the HPV vaccine, followed by more nuanced communication techniques such as motivational interviewing when encountering resistance. And so one of the same authors from that study also did this randomized trial where they looked at a 5-component intervention to hopefully increase HPV vaccination series initiation. And the 5 components were an HPV fact sheet library to create customized information sheets relevant to each practice patient population, a tailored parent education website, a set of HPV-related disease images. So my brother's a doctor, and he just loved showing me gross images of this, whatever he could find in his medical textbooks, so I understand that one. And then HPV vaccine decision aid, and 2.5 hours of communication training on what I mentioned before, which was presumptive recommendations and motivational interviewing. So, some conclusions. It's definitely a difficult task ahead. I think we need to recognize where each individual can have the greatest impact. You know, with clinicians, it may be like we just talked about in the way they have discussions about vaccination with patients. But you know, yourselves, scientists, and anyone can really engage in the fight against misinformation, whether it's through creating online social media profiles to counter misinformation, submitting complaints to the Competition Bureau or to Health Canada, et cetera. And for policymakers, I think we should consider in Canada some mandatory vaccination for HPV, you know, mandatory, obviously, to access public services, and then also consider stricter regulations or more legal accountability for the corporations hosting platforms for fake news. So that's thanks to everyone on this list, and yeah, I'm happy to be part of the panel.
Sure. You can pour yourself, grab your water or whatever. We have a few minutes for questions, just a few.
You as well.
And while you're formulating your question, I do have a question for Sylvia. My concern is that, and perhaps it's not a concern because our rates seem quite plateaued as far as our incidence of cervical cancer. But presumably there is a level of incidence beyond which you can't get public interest or public purse funding to be able to go further because people no longer see the disease as being significant or important.
What I think is that to reach this level, that you have to invest a lot. As soon as you stop doing the work properly, the incidence goes dramatically up, and that it was very clearly seen in the old URSS countries in Europe, no? When the political change was present and women were not enforced by law to have a screening test, otherwise they were not allowed to go to the dentist. A dentist, they could not access to the medical care unless they had a Papa Nicolau done every year. And so when this finished and there was a liberation of the political system in many of these countries, we saw increase in Lithuania and in Macedonia. In many countries, really, there was a dramatic increase of cervical cancer. So if we stop providing the funds to keep the rates, then things will go wrong. How much we need to increment the funds, probably, I think we have now better screening approaches and we have the vaccination. And probably with the budget we are allocating now to control cervical cancer, we can really do a better job because the new generations will be free of the virus. We will have, in the years to come, a better impact with the same budget.
So this is optimistic. And Blake, and I like that. And Blake, my question to you is that now that we have real world data, it's not a theoretic risk, but we can actually show that there's impact from the vaccine. Is that making the job easier?
It makes it easier to convince people who are skeptics, like people like most of us in the room who are fact-oriented people. I think that still there's a science communication problem that exists because there is this research showing that facts alone doesn't change anyone's mind. In fact, it can make them feel more the opposite way. So I think, yeah, like using narratives and combining them with facts is a very good, as that study stated, a very good way to move forward for sure.
Microphone two.
Yeah, hi. Thank you very much for interesting and useful presentation. I want to ask the panel how can I deal with a patient who actually received the vaccine and coming to my colposcopy with LSIL and positive HPV? I still have lots of those. I mean, the HPV of the rare causes.
you want to take that one, Sylvia? No, go ahead.
I don't capture.
Oh, the question is the patient who's been vaccinated but comes in with LSIL, and her
HPV positive screening, high risk, but not the same. I mean, the 45 or the other vaccine, other thing. I have 3 or 4 patients like this.
There are countries that they are now providing for free as the vaccine as they do for the young girls after a conization, after a treatment of a pre-neoplastic lesion. I think there is not yet a profound evidence that this is going to make a change. And the argument is that it may prevent reinfection of these women. And clinicians are very favorable to that. And I think it has moved this along more than the randomized trials that.
Your question, I think, is how do you counsel someone who has been vaccinated
and have an
primary and now comes in with an abnormal PAP? There will be types that aren't covered in vaccination. And the advantage is, this is why we have primary prevention, secondary at screening, and then tertiary with pre-invasive treatment. So I think you catch that one in the screening.
I understand, but as we are talking about the vaccination and anti-vaccination, these patients will be a voice of anti-vaccination because one of them has already paid $900 to have the vaccine and then still came back. So, I mean, I'm talking about how to deal with this.
Yeah,
You run the risk, I guess, of that person becoming one of the staunch anti-vaccination individuals and then trying to spread misinformation. Now, I'm not sure that would be as likely as in a case where someone believes they've been harmed by the vaccination. I mean, I'm a lawyer, not a psychologist. I'd love to answer the question, but yeah, I'm not sure I have a good answer. It's a very difficult situation for sure. I don't know.
I think nothing's 100%. And I guess one more question, and I see Renee on her feet, so one more question.
Thank you. I've been working in Australia the last 12 years, having practiced in Alberta for 7, so it's been a privilege to have a foot in both areas. We've just changed over to the new HPV screening program in Australia in November 2017. And what it has done is there's a transition period at which women have taken over the original pap smear driven cervical screening program and now going into the HPV screening cervical program. And so there's been a big public campaign for the doctors to manage this transition. The reason why I came up to say something was because our colposcopy rate has gone up by about 4.5 times. And it has completely overwhelmed our colposcopic services. Most of the recommendations have been that if you find HPV 16, 18, or the other non-16, non-18 oncogenic virus subtypes, have recommended a colposcopy to be done within 3 months. Now, there's suddenly been an avalanche of women coming in with these findings, and we simply can't fit them in. And we're having to make, the major centers are struggling. Women have screening done in pregnancy, and if they require colposcopy done in pregnancy, they have to be centralized to places where the skill is present, and the oncologists are overwhelmed. So I'm quite sure Canada would position itself to ensure that the service provision is there when they do the transition and learn from our suffering.
Yes, our modeling. If I could just say, this is being modeled at our Center for Cervical Cancer Prevention and Screening, and we do anticipate that with a move to molecular testing or to HPV testing, there will be a spike and it will come down. But absolutely, we're modeling that out and understand that will happen.
Because it means big volumes of women directed to a clinic that had a certain level of activity, and now you double. And sometimes these population-based programs do not account of this. It happens the same with the screening for colon cancer. You go into the population, and then you don't increase the number of pathologies. And you have so many polyps now that you have to be tested. So it's the same with cervical cancer. So
I hope you all believe that we are well positioned for elimination, and that there are some tools that will help us to get there. And I thank you very much for your attention today.